So moving on to the small molecule inhibitor options for this patient, there's a trial that was reported relatively recently, referred to as a RESONATE-2 trial. This was a frontline trial done for patients over 65 years of age who were randomized to Ibrutinib versus chlorambucil. So for that trial, maybe Matt, you can highlight for us the outcomes for that trial and the important features related to that trial, and particularly for this patient.
So I think one important point about RESONATE-2 to make just from the outset is that, as you just heard, the two standards that we might consider for a patient like this would be bendamustine and rituximab, or chlorambucil in combination with a CD20 antibody like obinutuzumab. So in the RESONATE-2 study, we see a comparison with chlorambucil monotherapy, which we're not typically using as a standard approach now. When this study was designed, that was still a standard approach, particularly in Europe, where a lot of the patients were put on this study. So I think it makes it a little bit challenging to compare across this population from RESONATE-2 with some of the other data sets that we just saw. But nonetheless, I do think RESONATE-2 is a very valuable data set because it was a large randomized phase 3 trial of over 265 patients, about 269 patients in total. And these patients were randomized 1-to-1 to Ibrutinib or chlorambucil with a primary endpoint of PFS. And I think there's several important findings from this trial. In particular, looking at the Ibrutinib arm, we saw a very nice progression-free survival at 24 months in the range of 85% or so, which I think is very encouraging for this population. As expected, chlorambucil had a much shorter progression-free survival. That's not a major surprise to us. But I think one of the things that I take away from the RESONATE-2 study is that patients with some of the higher risk markers, in particular those with the deletion 11q and the unmutated IGHV, had very nice progression-free survivals.
The presence of the 11q deletion and the unmutated V gene in terms of chemoimmunotherapy-based treatment puts this patient at higher risk for shorter progression-free survival and relapse and need for retreatment. How does that factor in terms of small molecule inhibitor-based therapy? What's the relevance to the 11q and the unmutated V gene in terms of Ibrutinib-based therapy?
So I think for the unmutated IGHV, we're seeing equivalence in terms of the progression-free survival in patients treated on Ibrutinib, irrespective of unmutated versus mutated IGHV status. And I think it's important to note that this has historically been very different with chemoimmunotherapy-based regimens, where we've always seen a shorter progression-free survival with patients with unmutated IGHV. So I think this is a very encouraging development in the field with Ibrutinib. Now, I think the 11q story is also very interesting. We had seen from the relapsed refractory studies, the 1102 study, for example, that there was a hint of a shorter progression-free survival in patients with deletion 11q. What we've seen in the RESONATE-2 study is a little bit different here, and we're actually seeing perhaps even a slightly better progression-free survival in patients who have deletion 11q, or at least equivalent. And that was seen in the RESONATE-2 study specifically. Tom Kipps and colleagues put together an integrated analysis where they looked at several different studies pooled together. And actually in that population, there was a significant improvement in PFS at 24 months in the patients with deletion 11q compared to patients without. So I think it suggests that Ibrutinib and perhaps drugs like it may help to overcome some of these traditional poor prognostic factors.
Maybe you can comment on the quality of remission with small molecule-based therapy, monotherapy, and what going on a small molecule inhibitor means in terms of duration of treatment, et cetera.
So one of the things with the small molecule inhibitors is that these studies that we've been discussing so far have been designed with ongoing continuous therapy. And so they require this ongoing therapy to achieve the PFS numbers that we've seen. We don't know what would happen if patients were to stop, but we have a sense that they would likely progress because most of these patients are not achieving a complete remission, let alone without MRD detectability. And so if patients are in a partial remission and stop a kinase inhibitor, we're probably not very confident that they're going to have a durable response. And that's why, as we'll discuss, some of the future regimens are combinations that try to achieve deeper responses and allow for time-limited therapy.
So CD20 antibodies are highly important in chemoimmunotherapy regimens. Clearly, the addition of a CD20 antibody has improved overall survival in the FCR regimen compared to FC. In terms of the small molecule inhibitors, particularly Ibrutinib, and looking first at the frontline setting, do we think about CD20 antibody with Ibrutinib, for example? Is there data that gives us some insight into that combination?
Yeah, so we have thought about this question, as has your group as well, looking at the combination of Ibrutinib and rituximab versus Ibrutinib alone, a study led by Jan Berger and colleagues at MD Anderson. And in this randomized study, we certainly did see more rapid improvement in the lymphocytosis as we see with Ibrutinib, but this did not translate into improved progression-free survival at this point. And so certainly there's cosmetic benefits of adding the antibody, but whether that's going to actually benefit the patients, I think think remains unclear. There are some ongoing randomized studies that may help to answer this question, including the Alliance study in the frontline setting, which in addition to comparing ibrutinib-based regimens to chemoimmunotherapy with BR, also has a comparison of ibrutinib versus ibrutinib rituximab. And so I think that's going to be an important study to look out for.